Before I move on, I wanted to reference a handout that you have that's called the Advanced Care Planning Flowchart. And this is a form that's on the Colorado Advanced Directive Consortium website, which is an amazing resource. They are who really brought the most form to Colorado. And I wish I would have known about this form years ago, because it's such a helpful guide on knowing what forms to fill out when. And with the most form, it really enforces the idea that it's not intended for people that are healthy. It's intended for people that have chronic and or serious illness, and to be the end of a conversation. So this is a handout that we're hoping that you use in your practice, not only in helping people complete the most form, deciding who to complete it on and what other forms are appropriate when. So what is the most form? That's a great question that Dr. Jackson did a great job of giving us the history so we understand the intention of it. The most form, it stands for, I'm sure many of you know, Medical Orders for Scope of Treatment. And it's the reason we're here today. It really is like a prescription for medical care. And so we wouldn't give a prescription to somebody, a blank pad, and say, you know what, you look like you're having pain. Go ahead and write yourself a prescription, and then I'll sign it. It's meant to be a well thought out, intentional document, and it's really helped to reflect people's wishes. So how does it work? It's a lot of information. We will probably reiterate 100 more times that it's meant for people with serious and chronic illness, and that it requires really robust conversation. It's meant to address the current healthcare condition of the person and their current wishes. Other advanced directives like living wills and 5 wishes reflect things you've documented in advance, but medical orders for scope of treatment are meant to be effective in what that person's wishes are right now, today. And that's why they hold the weight of being a medical order. And so that's an important distinction for people to understand. And as we've talked about, it makes people's clear choices and informed choices into orders. It's meant to stay with the patient. I think that that's something that we understand as a community, and that we understand also, we didn't always understand that copies were acceptable, but I think across the community we now understand. And the reason it's on green is so that it stands out, and that's why they prefer sending the original with folks, but copies are valid as well. The important point that I know I'll continue to make is it's only beneficial, it's only meaningful to fill out if it's actually referenced at a time when there's been a change in someone's healthcare status, whether that's in the hospital or in a skilled nursing facility or getting care in their home, wherever it may be. It's also truly only valid if it's available, if it's not put somewhere that people can't find it. I recently talked at a Parkinson's support group, and there's information out there about where to keep it. People thought they should keep it in a freezer, and that's, I don't know where that got out there from, but that's not that's not the place to store it. It's meant to be put on, if someone's in a home that has a refrigerator, it's meant to be put on a refrigerator if they're in a facility, to be on their chart in a readily accessible location. And it really only, again, to reemphasize, it's super important for us to make sure the family is part of the discussion, and I know that sometimes when there's a requirement to get it done, and family might not be present, to do whatever we can to have them be at the table. Because in the hospital setting, oftentimes if people haven't seen it before or weren't part of the discussion, then just like any conversation, how do we trust that that's what that person's wishes truly were? So that's an important piece as well. And some more nuts and bolts. And one of the things, when we were putting this together, it was really hard to know if we should put the nuts and bolts of the form before the conversation, because in practice, we definitely see the importance the conversation comes first. You don't even pull the form out until you've had a conversation about what their values are after you've assessed their ability to have the conversation, that you have the right people at the table. But it also made sense, so we decided to go ahead and go over the nuts and bolts of it. Each of you have a copy in your packet, and the first section is CPR, cardiopulmonary resuscitation. Actually, really the first section is the top part, and I think oftentimes when we're filling out a form, we look for the first blank area, but it's really important, I think, each time to review the first part, because it kind of reminds us of the importance of this, that there was limited space on this form, so every word on here was debated about countless hours so that people understood the best use of it. I think it's important, the very first line after the title is first, follow these orders, then contact the physician or advanced practice nurse or PA for further orders if indicated. And I think that's a culture shift of actually honoring a form. We always tend to want to go to that person, the decision maker, whether it's, in this situation, it would be the medical power of attorney. But in this case, these carry a lot of weight as orders, and so this is a place we go to first before we make a decision about doing whatever that's documented on the form, and to understand that they're medical orders based on the person's wishes. There's also important pieces if parts of the form are left incomplete, that if section A or B is not completed, full treatment for that section is implied. And even without this form, I think we all know that the mode of operation for our healthcare system is to treat as aggressively as possible. So for people that want to be a full code, want full treatment, we actually don't need to have completed a form. Some people want to complete it, but it's not necessary, because that's how we operate as a healthcare system, is we do treat. So that's, I think, an important point to make. And then it's only meant for adults, and everyone should be treated with dignity and respect, and I think some might say that goes without saying, but they wanted to put that on here. So then on the top right, the legal last name. Oftentimes these, I think, tend to be filled out, it looks like sometimes in haste, and to be mindful of the weight of these, to fill it out so that it's legible and people can clearly know who you're referring to. Then the CPR section, if people have chosen that they want CPR and they do want a form filled out, then that's where you would check that. If they don't want CPR, some of this I know is common sense, but that's what we're here for, is to reiterate sometimes common sense. This section A is only meant if you're taking care of someone and you find them and they are actually dead. They have no pulse and they are not breathing. If people choose CPR on this, they must choose full treatment. When people have completed these, there are times when in a discussion people feel like they want CPR, but then they also think, well, I want comfort, I don't want a lot of extra care, I've been through this and this. So if someone is choosing those things, then that's a time to step back and say, wait a minute, I think there needs to be more conversation and make sure they truly are understanding what they're choosing. Under the medical intervention section, I think Lisa Beth is going to go into a little bit of the detail when she's having conversations, but just as an overall guide, the full treatment section is for a person who wants kind of that full court press. They're okay with being in the ICU, they're okay with being on a ventilator, and I would emphasize that not only are they okay with it, but they're informed about it, that we do a good job of asking permission to share more details about that, so that people are making informed decisions. Selective treatment, the underlying part is avoid intensive care. That's when people are maybe in a position where they are willing to receive some additional care and maybe would want IV antibiotics or fluids or whatever. And then the third section, comfort-focused treatment. This section is where they're wanting to stay in the place they're in to really allow for a natural death. And we're in the process at the hospital of trying to change the language we use around end of life. And instead of saying, do not resuscitate, for example, saying, do not attempt resuscitation, because it's not a guarantee. And also to incorporate using the language about allow natural death. An important piece here for the folks in the community, I think that the last line under C, it says, do not transfer to the hospital for life-sustaining treatment. Transfer only if comfort needs cannot be met in current location. And I know I was, in the time I worked in skilled nursing, that oftentimes if people had a form that this was checked, if they did fall and we weren't able to meet their comfort needs at that current setting, we would sometimes send them to the hospital, and then we would hear, oh, they were maybe in the ICU or getting additional treatment. And I always wondered what that was about. We'll talk about that more as the day goes on, but that goes back to why it's so important to have robust conversations around that so that the wishes have the best chance of being met, because there's a human factor involved anytime you have a form like this and you're talking to humans. But to do our best to only transfer people if their comfort needs cannot be met, and to allow and to do a good job of communicating that to the next level of care, that they understand what the goal of sending them to the hospital, for example, may be. And the same thing goes when we transfer people to the hospital. The artificially administered nutrition, that section is one was on the previous form and continues on this one. This one is also something that's on the, oftentimes on living wills. And I know this one I'm not going to go into as much detail, but one of the things that's important to note here is some of the information that is written at the beginning, where any surrogate decision maker must follow the directions in the patient's living will, that because this information can be on a living will, it's so important for us to, before we start this process, make sure we've asked for people to bring in any other advance directives that they've prior completed, so that we make sure that whatever they've filled out on a MOS form matches what's on their living will, because the level of confusion it can cause when people have different wishes documented in two different places, it can really be confusing when people are trying to really follow what that person would want. And then, of course, there's the section for who did you discuss this with, and that goes to how important the conversation piece is. And then it's super important that the whole bottom part is filled out, that people print their name legibly, complete their information, including their license number if they're filling that out. And then on the back, additional information. Many times when we're completing the form, there's times where, again, it's good to take 5-10 minutes to read this, to reiterate or to become more familiar with the language. One of the things that's highlighted on the back is that completion of the MOS form is not mandatory. It's definitely something that we want to get that message out, that I know there's a big push in our state for people to complete this form and in our community, but we can't make it mandatory. And also, it's really most important to focus on having a robust conversation, including the family, and then completing this as an outcome of that. And then if people have completed a form, a real quick statement I wanted to make is the very bottom, to void the form, you need to draw a line across the top 3 sections and write void in large letters. Then sign and date it so that if people do find 2 competing forms, they can know which one has been voided. That it's not something that you just rip it up. You have to put that information on there. So staff competency, that's again like what we're here today to talk about. One of the things that I want to reference in talking or spending some time on this slide is there's a couple of great references from the Colorado Advance Directive Consortium that are in your packet. And the first one is the Medical Orders for Scope of Treatment Frequently Asked Questions. It's a great guide. We won't be going over all the details of it, but it has a lot of great information that I would hope each of you would take the time to read before you help somebody complete a MOST form the next time. The handout we'll spend a little bit more time with is the more about the MOST, because this is really what we patterned our education on today, that the importance of determining capacity, explaining the process, because it can be scary if you're brand new to someone, you've just met them, to then jump into completing a serious form like this, or having a serious conversation like this. Again, asking for any documents, explaining what the agent's role is, and exploring their understanding of their medical condition, like Dr. Jackson referred to, referring back to prior experiences, exploring their quality of life. And then number 9, nearly the end, is where we actually introduce the MOST form and then complete it. So these are 2 great handouts to have in your toolkit when you begin helping people with this process. One of the first items on here, gaining sufficient expertise to discuss medical conditions. I know oftentimes people that are helping folks with these forms maybe they're not a nurse, or maybe they're someone with a different level of education, but there's some of the topics here, you can definitely become more competent in understanding the medical conditions. But that being said, if you're getting into a conversation with someone and you're not sure how to answer the question they're posing, then that's again a time where you can say, kind of step back and stop and say, you know what, let me, hopefully you've kind of gained, before you've even pulled the form out, an understanding of, will you be able to have this conversation if they ask more complex medical questions? But it's okay if you don't feel like you have the expertise to answer the questions, to say, you know what, I don't know the answer to that. Let's talk to your nurse practitioner. It's more important for us to get this filled out well rather than getting it done today. So let's not proceed. Let's wait on that, and you can then focus on more of the values conversation about their goals of care and what they want, and then relay that to the provider or to the nurse practitioner or physician. But today we're wanting to help everyone feel a little bit more comfortable and competent in having the conversation. And another piece is being able to assess decision-making capacity. And I know that's something that often is misunderstood, and we'll be going into more detail about that. So really the first question is, when should we complete a MOST form? In the hospital, again, like Dr. Jackson said, it should be incorporated into the discharge process so that anyone that qualifies for this, that they leave the hospital with this form completed. And we're working hard to do a better job at UC Health to do that. I know Banner also has an initiative to do that. So in home health, if persons are receiving home health and don't already have one, it should be included as part of the advanced care planning process. And then, of course, in hospice, it should be incorporated into the admission process. I think some of that's common sense. And then in primary care, this is really, in my mind, the best place for these conversations to begin, because it's not a crisis. You have a little bit more time to have the conversation, to build a relationship, to prepare the family, to begin to plant the seeds of this important conversation, rather than waiting until a medical crisis. And our hope, even though we're here as healthcare professionals to have this conversation, each of you has a family, and each of us individually, if we have a family member, we can help be the stewards of, you know what, I've learned this information, and I've learned how important it is. Not all physicians and nurse practitioners are comfortable having the conversation, but as a community, if we can come together and kind of begin to ask that of our healthcare professionals, that each of us could help our family members that are appropriate get this important conversation started. And again, even though we're talking about the MOST form today, I think it's important, every one of us needs to have conversations about what our end-of-life wishes are and begin to share those with our loved ones. But in primary care, it needs to be part of a routine checkup. Then in skilled nursing, which is oftentimes where this form is seen as being the most completed and most used, because those are folks that are, by definition, typically chronically or seriously ill. It should be completed at the earliest opportunity, but again, as appropriate. If there's somebody that's being admitted that isn't chronically or seriously ill, is being admitted for rehabilitation of their knee, for example, and doesn't have other health conditions, I know it's a requirement for advance directives to be reviewed within 72 hours, but we want to emphasize how important it is to only do the most form on those folks that meet the criteria of being chronically or seriously ill. And again, the ideal would be that we have time within the first 3 days, if somebody is appropriate, to get the conversation completed and the form completed. But we don't want to sacrifice the quality of the process for the timeliness. And that's something that if I could have one takeaway, which I know I'm going to want to have 100, but it would be that one, that this be something that is a mindful process that is given the time that it needs to occur in the best possible way. And then I know that having worked in long-term care, the care plan meetings, I know there's a lot on those agendas, but that's a great time where the family's together to where, ideal or in a dream world, I could see that would be an important part of those quarterly care plan meetings, to have a section of it be devoted to having open conversation about what someone's goals of care are, what their wishes are, what their values are, and then if they don't have a MOST form, to have a plan to get it completed around that time. Preparing and building the foundation. So before completing the MOST form, what do we need to do? Again, reiterating, the first thing we need to do is obtain and review previous advance directives. This is something that I know oftentimes families are very stressed and they maybe don't have the forms, or they think they're there at the doctor's office, but to encourage and to continue to remind folks that we need to have those documents, and that's part of the expectation, just like needing your insurance card or your whatever, those documents, we need to bring them in as quickly as possible. If families can't get them, I know or if they think they're in the hospital system, there's an easy way for now internally in the hospital for us to find them pretty quickly if they didn't get sent with the person. In Epic, they're really a couple clicks away. We've done a better job of making these important forms very accessible. So before we begin conversations, we need to find out what previous advance directives have been done. And the next thing is to have a good understanding of what the person's medical condition is, their prognosis, and what kind of course what kind of trajectory they're on. Because if we don't have that information, for one, we don't know if it's appropriate to complete a MOST form, and not understanding what their prognosis is. If we say, what's your understanding of your current situation, of your illness, and if we haven't taken the time to understand that a little bit, then how do we have a meaningful conversation if we can't know if their answer is accurate? So to take the opportunity to inform ourselves about what is their condition, and then to feel comfortable. And I don't know that this happens, but the idea of calling a provider and saying, we want to have a conversation about this person's goals of care, their end-of-life wishes. We're hoping to be able to document it on a MOST form. Are there any thoughts that you have? That could be a really powerful few-minute conversation with the provider, because they will have had a trajectory likely of caring for that person for many years and can download that to your brain in a pretty short period of time. That could make the conversation go much more smoothly, especially if you are then able to say, when you're connecting with that family and that patient, to say, I've spoken to Dr. So-and-so, and bring that up in the appropriate time in the conversation. And it can really do a lot to build rapport, and that you've cared enough to find out that information from them. Then the next piece is assessing decisional capacity. And again, I'll be going into that more because and I would say I've been guilty of it as well. I misunderstood the difference between competency and decisional capacity. And so, like I said, we'll go into that in more detail. And then the importance of contacting the medical power of attorney and scheduling a time with the patient, with the medical power of attorney, to have the conversation. And I know that this is likely a change in the way we do things, but I think it's could be such a powerfully impactful, important change to make sure that power of attorney is present. When I think of my own situation with my family member, like I said, I was hesitant to complete the form because I was actually told by one of her providers, let's wait till her cognition improves, and she had dementia. So how is that going to improve? But I took their advice and thought, let's wait. And if that had been something where they're like, we're going to sit down and have this conversation, I would have felt like I had a partner. And I'm hoping that each of you, when you think about changing possibly the process, is to consider it as an opportunity to build rapport, because I wonder, even in our healthcare system overall, how we often enact a plan before we've really sat down with patient and family and pulled out what their goals are of different treatment. They many times trust that if we're doing something, that it's the right thing to do. But I think in all of healthcare, we need to do a better job of having the conversation about what their goals are, even if it's not end of life, but most especially, and because that's what we're here to talk about, for end of life, to have these upfront conversations so people can make informed decisions. That it can make all the difference. I know that with countless families that I had the opportunity to help with this process, I learned that when I was doing it in isolation, that it wasn't nearly as, not only not as reflective, but I really missed an opportunity. And when I was able to have conversations with people in the long-term care community after we had a little bit of chance to know each other and build some trust, that it was night and day different, and that I had a better idea of overall what their care could be. So determining decisional capacity, we've devoted several slides to this because when we were thinking of putting this presentation together, this is one of the things that we felt like was a gap that people did want to know more about, and that so we have a little bit more in this than you might have been exposed to before. So I know this first slide has a lot of information on it, and you won't be asked, there will not be a quiz. But it's so important that any advance directive and the most form really should only be completed after decisional capacity has been determined. And it's not something that many of us realize that we do every day. So we'll be going into kind of the nuts and bolts of what it looks like. And another key point is people oftentimes think if I'm your medical power of attorney, that like my sister's mine, she's not going to be making decisions for me unless I don't have decisional capacity. And oftentimes when people are sick in the hospital, family members or the medical power of attorney oftentimes think, well, no, I want her to have that treatment. Maybe the patient is saying, no, I don't want that, and they have the ability to express that if they have decisional capacity, that the medical power of attorney doesn't have a right to override the person's wishes. And so that's an important point to make about decisional capacity. There are circumstances that are rare where someone will give their power of attorney what's called, I believe it's called standing power, but that doesn't necessarily matter. It's more what it means. If somebody wants it to take effect right now, that's still, even if someone's medical power of attorney is effective immediately, that doesn't mean that medical power of attorney can go against that person's wishes. They still have to obtain consent. And hopefully, if you come up with a situation where that occurs, where someone does seem to be wanting to exert their authority as the medical power of attorney, to understand that that's not okay, you have to have the consent of the person that's receiving the treatment, or the consent of the patient. Decisional capacity, oftentimes people think that that's something that you need a psychiatrist or a mental health provider to perform that. It can be completed by any healthcare provider can determine decisional capacity. It's different from competency. Competency is a legal term, and everyone is assumed to be competent unless they've gone through a legal process to whereby they've been determined to be incompetent or to be not competent, to not have competency. People do use these terms interchangeably, and so hopefully in our community we'll realize they are different. And I still once in a while catch myself saying competent when I mean to say they lack decisional capacity. Want to make sure I cover all the points here. The decision-making capacity, on the other hand, it's a clinical term. It's task-specific. Any healthcare provider can determine it if they learn the components of it. And I'll give an example in a minute. So again, I know to emphasize, we shouldn't be completing a MOSE form or having an isolated conversation with just a patient if we haven't assessed that they have decisional capacity. So any of us should be able to do that and can learn the skills to do that. So there's 4 components. The first one is understanding, and there's a form that has been developed by University Hospital to help clinicians understand what questions they need to ask. But the first idea behind decision-making capacity is, do they understand? Do they understand their current condition? So the question you can ask, and Dr. Jackson spoke about this, can you understand your medical problems? One of the questions here is, why are you in the hospital right now? What have you learned from the medical team about your illness? And if someone isn't able to capture that information and reflect it back to you in a meaningful way, I mean, it can be pretty simple, then they lack decisional capacity, and then you know that it's not okay to then proceed and have a robust conversation about their end-of-life wishes without their healthcare agent there. Expressing a choice. Are they able to make a choice regarding what treatment options are available? And oftentimes people can express a choice, so this one is a lower bar, but that's part of decision-making capacity. And can they appreciate the situation and the consequences of their decision? And so, do they have what could happen to you if you have the treatment is a question. How could the treatment help you? Can you explain what problems might occur because of the treatment, so that they understand and can appreciate the decision that they're making? And the final component is reasoning, which is the patient able to communicate the above in his or her own terms? Can they reason? Can they rationally reason about how they reach this decision? So those are the 4 components of decisional capacity. One of the sort of like, when on every person do you do a more intense undertaking of decisional making capacity? Because we do that every day with each other. If I ask you a question about something and you reflect lack of understanding, I right away begin to question, even though I don't call you decision-making capacity. If you can't tell me back what I've just said or the situation, then I immediately, as a healthcare provider, I begin to question, maybe I shouldn't be talking to you about this. We often do that right away with people that have cognitive impairment or dementia. although what Dr. Jackson was saying is very true, sometimes people with mild to moderate dementia, they should be involved in the discussion, and they can understand some of the concepts of it. But if they can't fully understand and reflect back to you an understanding, then we need to make sure we have other people at the table. So when do we do a more thorough decisional capacity assessment? Is when someone has had an abrupt change in their mental status is one of the possible times. Also, we do that if they've made what seems like an unreasonable refusal of a recommended treatment, especially if it seems like it's due to a lack of understanding on their part, or if they've given hasty consent to something that seems very risky. And I would wonder sometimes when I was learning more about decision-making capacity for today, sometimes people make a very hasty decision about, oh, yep, I would want CPR, I want to stay alive. And oftentimes, in my mind, that's a pretty hasty decision, especially if there's someone from an informed healthcare consumer's perspective that would warrant me asking more questions about their understanding of that decision that they're making. Another time when you'd want to assess decisional capacity is if there are cultural considerations or barriers, language barriers, an educational level, and if someone is very old is the criteria that I've seen reflected in the literature. So again, to kind of reiterate, to kind of make it hopefully seem more simple, because I know it sounds like a pretty complex process, but just by asking a few questions, what is your understanding of your current condition or situation? Can you tell me what the risks and benefits of these interventions are, and maybe what some of the consequences might be for you? And sort of like, why do you think that intervention is a good choice for you, kind of that appreciation. And then kind of seeing how they're weighing the pros and cons. And there's definitely more information there's a lot of great videos on YouTube where there's psychiatrists and mental health professionals, because of a lack of understanding that healthcare professionals can do this, that there's videos that they're working to educate the public and educate healthcare professionals about the importance of not only understanding the difference between competency and decisional capacity, but understanding that each of us can do this if we learn a little bit more information about it. So there's also a handout here that this one is from Up to Date, which is a online resource that the hospital subscribes to that's helps understand or explain it a little bit in more detail so that each of us can become a little bit more familiar with it. A quick example that I could give is I had a gentleman that I was asked to see that had Alzheimer's dementia, and he was his wife's medical power of attorney. And luckily, the family was also present and very involved, and they were the ones that actually were, because we don't always speak to the right person sometimes, we go to who's most convenient. So the daughters were also involved in the situation and being supportive of the husband, but again, he had Alzheimer's beginning stages. So it was pretty simple to assess his decision-making capacity, because he was being asked to make decisions about whether his wife would benefit or not from CPR, whether that this was the best choice for her in the ICU. And so just asking the question, what's your understanding of your wife's condition? And he very simply stated, pretty straightforward, I think she's dying. She's been sick for so many years, and I don't think she'd want this. She talked to me about things, and I think that it's hard for me about, letting her go. I want her to live. I'd like her to live. I thought that I would go first. And he wasn't quite that eloquent, but that's the parts of the conversation that I was able to pull out by just asking him what's his understanding. Then his daughters would kind of chime in a little bit. And then his choice, I didn't even have to ask him. He's like, I don't want her to live this way. And so he understood that. And then his appreciation of that, he knew the consequences. He said, I'm going to miss her. I know. And so he understood the situation just by asking the simple question. And I didn't have to say, okay, I'm going to get out this form and ask you these really technical questions, because I'm assuming you might not know what I'm saying. You can build it in a very gentle way into a conversation. Another important point about decision-making capacity that they talk about, that it's task-specific, meaning someone may have the decision-making capacity to say, you know what, I'd really like toast for breakfast. That's a decision. They have the capacity to say they want that. It's a pretty low-risk decision. And so somebody might be able to say what they want for breakfast, but will they understand the complexity of the benefits and burdens of, for example, like a hip replacement surgery? So oftentimes people think of decision-making capacity as either you have it or you don't, and that's not the case. It's definitely something, it's task-specific, and it's time-related. People may have decision-making capacity in the morning when they're more bright and awake, and then as the day progresses, and sometimes people with dementia experience more confusion in the afternoon. So it waxes and wanes. It's not only time-specific and task-specific, so it's something that we need to be assessing with each decision, and you're not going to assess it well with toast. But if it's a serious decision about medical treatment, then there's a higher bar there. That's why it needs to be assessed on a more clear basis. So again, to reiterate, people don't either have decisional capacity or not. It's task-specific and time-sensitive, and it's a process. And I would encourage each of you to become comfortable in the skills around decisional capacity, and even Google it. And there's a great video on YouTube, like I said, where they do it and they have examples of it so that it's a natural part of our process. So as a community, we begin to do a better job of that. Because I think even with my mom or my family member, if we had, her understanding was very limited of her illness. And I want to make sure I don't sound like I'm blaming anyone for that. I think we do better when we know better. I didn't know at the time, so I hope each of you will consider bringing this decisional capacity as a priority into your workflow. Then preparing the family. Providing the conversation project starter kit to patients and their families in advance of the most formed discussion is something I'm really excited to say. We have the booklets in your packet. It's something we've been doing in the community, these conversation starter kits. And there's one for dementia and one for people that don't have cognitive impairment. It would be a great tool for us to begin to hand every family member and patient and say, you now have the gift of the opportunity to have this really wonderful conversation, and here's a guide to help you have this values-based conversation. It doesn't start with, Mom, would you like CPR or not? Because that's definitely, we don't want to ever use that language. It's, tell me about your values, and giving people an opportunity to envision what they want their end of life to look like, and then planning backwards from that. We picked the Conversation Project Dementia Starter Kit, but there's also a great resource from the Alzheimer's Association. And again, preparing the family is such a key piece of it, and asking them to bring in the advanced directives and kind of to build excitement and to the importance of this conversation, rather than it being something that's seen as a burden, but to be seen as an opportunity for people to engage in a really meaningful way with each other in the face of a crisis. And then also providing simple decision support tools. I think oftentimes we ask people to make decisions based on limited information or information they've just gotten off the internet or off of TV. And there's a lot of great decision support tools we'll talk about at the end of the day, so that people know what it means to receive CPR, know what a tube feeding, when it's indicated, and having some understanding of what that looks like. And always with any of these resources, it's so important for us to ask permission to share information with people. And so, kind of in closing, I think that preparing the family is really a time for each of us also to prepare, to begin to normalize the language around changing our view from we need to complete this form, because I even find myself still sometimes going there in my verbiage, but to saying things like, you know what, we've learned in our healthcare system that we don't always think about what, asking patients and their families what they want and allowing them time and space to have important conversations about what that person's end-of-life wishes are and what they would or wouldn't want, and then providing an opportunity to educate them with some of the simple tools that have been developed, that I feel like it could really transform our culture from one where we look at death as a failure to looking at death as a natural part of the life trajectory, of that it happens to each of us, that the statistics just recently are that 100% of us still die. And so to make that an opportunity to prepare for death like we prepare for new life. We do a beautiful job most of the time when new life is coming into the world, and to begin to do that as a society, especially up here in northern Colorado, where we have an amazing effort because of the grant that we got from the Colorado Health Foundation that the Larimer ACP team is working under, that we have an opportunity to make a tremendous difference in our community. And it's really because of each of you that as you leave here with hopefully these helpful tools, that you'll be able to begin to infuse that into your work. And oftentimes some of the research about when you will use new information is you have to feel 70% confident in it. And so I would encourage you to practice, maybe even to practice with each other, and we'll have an opportunity a little bit later to practice some of the conversation, but to practice it so that we each begin to feel more comfortable in doing it, so that we actually will feel skilled enough to have the conversations, because I know it can be the most meaningful part of your career. So thank you.